Right, so now we're going to talk about spinal cord injury, which is like really devastating disorder. All right. So how are we going to define it? It's tears in the ligaments that stabilize the spine. So what are the causes? The causes are basically sport injuries, falls, depending on how fragile you are. It could be like an elderly client. Violence, motor vehicle collisions are really common. So it could be many different things. All right, so how are we going to classify things and assessments, and what are we looking for as the physicians? All right, so diagnostics that they're going to look for is their MRI, CT scans, which are kind of preferred, and x-rays. So those are their diagnostics, and American Spinal Injury Association impairment scale can be used. They use dermatomes to basically monitor, look for the damage in dermatomes, because they say motor and sensory closely align with each other of damage. All right, so there's a primary injury and there's a secondary injury. So what does that mean? That just means basically that the primary injury is the initial injury, and the secondary injury includes the progressive damage that is done due to the inflammation cells. So this can cause paralysis within 24 hours that could have been prevented. So basically what I'm saying is basically that that they can cause damage basically 24 hours after. So monitor that, and inflammatory cells can cause the initial so primary and secondary. And secondary is from the inflammatory that happens 24 hours after. And that could have been prevented if medical intervened, basically. All right, so the mechanisms of injury. We have different classifications we use. So we're going to be looking at flexion, hyperextension, flexion rotation, extension rotation, compression. What does that mean? So flexion, we're talking about our whiplash. So what happens in whiplash? What does that even mean? So flexion, we're going to be thinking about whiplash. So let me show you. You go back in whiplash when you're in a car accident, and then you go forward. So what are you braking? Let me do it one more time. Back, like this. Back. I think you get the point. So basically, what you're affecting is the posterior ligaments of your spine. That is correct. So, okay, posterior ligaments of the spine getting affected, you're getting pushed, and then forward, you're gonna affect that spine area, and it hurts. So the flexion is flexing. So think of your wrist like this, and then you flex it. So you're flexing forward. So it makes sense. All right, so hyperextension, basically, think of your chin. So I'm gonna do an example like this, and you go like that. So let's say there's a table here, and I go, where are you braking? You're braking your anterior ligaments. Exactly. So that's exactly what I'm trying to say. So hyperextension just means this, and flexion just means this. So flexion breaks what? Your posterior ligaments. Extension breaks your anterior ligaments. So that makes sense. Flexion rotation, I like to think of falling off a horse. And compression is just like that force, the bony fragments, you go into the spinal cord. But how would this happen? Think of diving. You like a head trauma right at your head. So you dive, you go, and then you hit your head, and it just compresses all down. And that would really hurt, and that can cause spinal injuries as well. So watch for that. The level of injury is just another classification used. So what we were talking about before was the mechanism of injury. The level of injury is basically talking about the skeletal level and the neurologic level. The skeletal level is when it's just talking specifically about the ligament damage, the damage that is done to just vertebral and ligaments. If there is a neurologic level, that means we go on this level number 2, where the cervical damage is associated with tetraplegic. That's where you have hemiplegic, paraplegic, thoracic, lumbar, sacral, usually associated with paralytic. So that's what we'll be looking for in neurologic. We're looking for that basically. We're looking for the neurologic. That's what we're going to be focusing on a lot during when I explain everything mapped out perfectly. Okay, so the degree of injury also could be complete involvement, incomplete involvement. Sometimes it's a little mixed mosh, but that's where I'm going to explain. All right, so clinical manifestations, I kind of merge the interventions and the clinical manifestations together, but I promise I will also explain interventions on a separate note and make it more clear. Okay, so just follow along with me. All right, so clinical manifestations, I break down to each body system. Now, it's really important to know we're affecting every single body system there is out there. It's like every body system gets affected. It's really devastating, and spinal cord injuries are just terrible. So it's really important that the nurse tries to reduce and make sure they're on top of everything to reduce the amount of damage that happens, especially since secondary injury can also worsen the symptoms and make paralysis that's not reversible or that could have been reversible. So think about that. All right, so we're gonna start with integumentary system. What do we worry about when it comes to the integumentary system? We're worried about pressure ulcers that may develop due to the lack of sensation. So that's the main thing we want to look for. What are we at risk for when we can't feel and we have a pressure ulcer and there's open wounds happening if it's not treated or they're not, rotated every 2 hours? We are at risk for infection. We're at risk for sepsis. There's so many things we're at risk for, and we have to monitor for that. Now, gastrointestinal is the next system I'm going to be talking about. So what are we worried about? We're worried about gastrointestinal stress ulcers. We're worried about above level what? Don't forget this. Seriously, don't forget. T5 or above will result in paralytic ileus and gastro distension. Why you're going to be distended? Because you're literally going to be, let's say you ate something and it never digested. You're going to feel so bloated. All right. And also, why are you affected by stress ulcers? What makes you at more risk? And what if you can't feel the ulcer and you're like, I didn't know I had an ulcer because I don't have sensation? So intra-abdominal bleeds may happen, and they may be difficult to diagnose because there is no pain or tenderness when these patients, they can't feel it. So that's really dangerous. So you want to make sure to monitor their hemoglobin, their hematocrit, and expanding girth. If they have an expanding girth, you may want to be like on top of that. Their hemoglobin, they may have a lax oxygen, hematocrit may go down. You want to make sure that you're aware if there is a bleed that happens, because they may not know to be able to tell you, and it's the nurse's job to realize, oh, I should be looking for that. Okay. So above the T level 5, they're going to have paralytic ileus. We talked about that. So how are you going to relieve this gastric distension? NG tube to relieve the gastric distension. And then are we going to help with motility? There is a drug. It's called metoclopramide. Metoclopramide. So this helps with gut stimulation with associated with gastroparesis. All right. So now let's talk about the urinary system. So we talked about integumentary, gastrointestinal. Now we're going to talk about the urinary system. So what are we looking for? What number? T12 or below. That is right. T12 or below, we're going to see neurogenic bowel irreflexia. What does that mean? That just means your bowels are not working, basically. So post-acute, but post-acute may see something different. You may become hyper-irritable with reflex emptying. Basically, you're not in control and it just like spasms out. And you just like can't control your incontinent. But after that, you're going to be T12 or below, you're going to be areflexic and not going to have any function to your bowels. All right. So the bladder is atonic and becomes over-distended. This is dangerous. What are you going to do for this patient? All right, you're going to do a straight cath. Why are you going to do this? You don't want that bladder filling up, because if it fills up, it just basically, and it doesn't like relieve. Think about it. Your urinary system looks like 2 roads and it goes in a like that. If it keeps going up, it's going to cause infection because your kidneys are up there. So it just gets like, you just don't relieve it, it's a problem. So you've got to straight cath them and get the fluid out, because it's a risk for infection. Even though the catheter makes you at risk for infection, just being full of bladder makes you at risk for your infection to yourself. So make sure you use sterile technique when it comes to the catheter and intermittent catheterization. You want to do the straight cath, remember that. All right, so for the peripheral vascular system, we're at risk for venous thromboembolism, pulmonary embolism, deep venous thromboembolism. How are we going to know this? Why is it hard to find? It's hard to find because they have a lack of pain and sensation. Again, just like your stomach, they have a lack of pain and sensation. They're a risk for stress ulcers. They're also a risk for DVTs, even higher risk because they can't even tell you if they have pain. So it's really dangerous. Other things to look for. So what are the diagnostics that we're going to use in order to even be able to monitor for this if they don't have healing? Duplex Doppler ultrasounds, impedance, venous occlusion, all that stuff. So be able to monitor for that. The next thing I want to talk about is cardiovascular. Hold on. All right, so cardiovascular, we're going to be looking at above what level? Above level T6, what's going to happen? Not good news either. Above level T6, it greatly reduces the sympathetic nervous system. Remember the one that makes people go like me, like crazy? Because I'm on drinking a lot of coffee, because I love coffee. All right, so above level T6 greatly reduces sympathetic system. Think of reducing sympathetic system, meaning reducing that fight or flight. You're gonna get bradycardia, hypovolemia, hypotension. Bradycardia, hypovolemia, and hypotension, all the hypos. What are we concerned about? Let's look at the notes. So a heart rate less than 40 beats per minute is what we're looking for. Peripheral vasodilation reduces venous return. This is very, very dangerous. So you can see that venous pooling. What is regular? I'm pretty sure 60 beats to 120 beats is normal. So that's really really low. What are some drugs we can give them to increase their heart rate? So you can decrease their inhibit the parasympathetic system. How? A drug called atropine. What is atropine? An anticholinergic. Remember the side effects: constipation, dry mouth, all that stuff. Yeah. And because they have hypovolemia, you want to reduce the risk of hypovolemic shock. So what are you going to give them? Fluids. Why? Well, or vasopressors. Well, you also want to give them vasopressors, dopamine. We'll talk about that later. And to maintain the blood pressure, we're trying to get them at 90 at least mmHgs. All right, so now that we know about cardiovascular, we got to talk about respiratory. This is super important because they may not be able to breathe. All right, so respiratory, they may have respiratory abdominal muscles and intercostal. So if that happens, they have problems. This is often associated with the cervical or thoracic injuries. Other ones to think about is, okay, so the main thing I want you to remember is C4 or above needs mechanical ventilation. They can't breathe. And why can't they breathe? It's not like directly linked. It's basically their diaphragm is not working. C4 above, diaphragm not working. Other reasons that respiratory may be damaged anyways, even despite the C4 working, let's say, is below C4 can also be affected if there's edema or hemorrhage affecting the phrenic nerve. So just remember that, the phrenic nerve, and causes respiratory insufficiency. So regardless of C4, you may still have respiratory problems, so watch for that because of the edema and the hemorrhage affecting the phrenic nerve. So the nervous system is also affected. Basically everything is affected. That's what I was trying to say before. So the phrenic nerve, we're looking for quadriplegic. That's like, quadra is 4, so your arms and your legs, just everything basically. Hemiplegic, we're thinking it's affecting only one side of the body, so think it did some damage to one side of the brain. Think of like strokes. Hemiplegic, think of hemisphere. Hemispheres are symmetrical, so remember that. Damage to one side of the body. Just remember, damage to one side, only one side. Hemisphere, symmetrical, only one side. And if it does damage on this side, it will affect that side. If damage on this side, it affects the other side. Another thing the nervous system it can cause is T6 is associated with paraplegic, so right at the chest, paraplegic. So para, I think of part, so part does not require it to be symmetrical, so P for part, like part of your arm. It's not symmetrical, it could just be below. So there's different levels of paraplegic though, so just be aware of that. Because metabolic, we're gonna be thinking about the interventions is why you have to think about the metabolic also. So like watch for fluid electrolyte imbalance, especially if they're on an NG2, because if they have paralysis to their stomach from T5 or above, paralysis to stomach, they could be at risk for alcohol because they're taking the acidic out, they could be at risk for being alkaline. Weight loss is really associated with that because they may not be eating, especially if they don't have swallowing control. High protein to decrease atrophy and prevent skin breakdown. So high protein to decrease, remember high protein. You don't want to promote healing. And thermoregulation. There's disrupts the body temperature regulation to the affected area, or it's including the ability to sweat or shiver and the affected area of the injury especially. So monitor thermoregulation. All right, so now let's talk about our interventions. So let's talk about what we immediately want to do. So our main concerns are maintaining a patent airway, adequate ventilation, breathing, and circulating of the blood. Remember peripheral vascular system, basically your ABCs, just remember ABCs and you'll know. Then the airway, the breathing, and then the circulation. And preventing the extension cord damage, so you don't want to cause more damage. And that's when we're going to talk about non-operative stabilization of immobilization, because you want to immobilize just like your fractures. All right, so you want to decompress realignment or traction you may be using. But remember the rigid cervical collar and supportive blocks on a backboard with straps. That's super important. Make sure you immobilize those patients because and keep them in line as much as possible. If you're transferring a patient, use log row method. That's when you don't actually move your spine at all. So that's really important to know. So when you're using a draw sheet, make sure you use your correct technique. You're not moving their spine at all. And that's really why you have that supportive block board at the backboard, to make sure that they're mobilized. And all right, so the question is, you want to think about drug therapy, low molecular weight heparin, but it's not used in surgery, and it's not used if they have a hemorrhage. So remember that. It's contraindicated for surgery or hemorrhage. But after surgery, that's okay. All right, for vasopressors, we want to be looking at, because of that low blood pressure, vasopressors, we're thinking of our bradycardia. That's trying to go there. T6 or above, bradycardia. Bradycardia and hypovolemia. So you may have to give them vasopressors. And we're trying to improve that perfusion when it comes to vasopressors. So just remember the goal is to maintain blood pressure above 90 mmHg. All right. So those are the drugs that we were going to focus on. Other things to look for is, did they have their tetanus? Check for their history of the patient. Immunizations. Tetanus shot is really important. You may have to discuss sexuality concerns. It may not affect infertility. Don't give it a solid yes or no, because it may not affect it. And it may affect orgasm ability. So yeah, they may need a lot of psychotherapy help and coping, and it's really stressful. All right, are they a candidate for surgery, for surgical? So this kind of really depends. Is there evidence of cord compression? Is there progressive neurologic deficit? It just really depends, because there's obviously spinal cord injuries are associated with damage. The question is, would it actually help or not when it comes to spinal cord injuries? So it just depends. All right. Now let's talk about what are we going to do to monitor. Now these patients are going to be in the IC unit, very severe cases, or surgery. So they have no temperature control below the level, so no vasoconstriction in the area. So vasoconstriction is often used to control temperature, so in the area of the limbs. So monitor for the environment, make sure it is suitable for them so they're not getting too cold or too hot, especially since they have a hard time controlling their temperature. With a neurogenic skin type, not being able to feel sometimes, you have to monitor their skin. Reposition how long? Every 2 hours, that is right. And air mattresses are used as interventions to help with this. For neurogenic bowel and bladder, remember T12 or below, they're not in control of the bladder, areflexic, atonic, whatever you want to call it. If you also want to make sure, like, there's kind of overlapping concepts when it comes to this. If their bladder gets so full, their blood pressure might skyrocket it, and they may have signs of headaches. So this is a sign of that what you have to do as a nurse is give that straight catheter in, or Foley catheter, to make sure that the bladder's not extended Make sure you use aseptic technique to prevent caught eye. Indwelling or intermittent may need digital stimulation. And every 3 to 4 hours. Every 3 to 4 hours is how many times you have to relieve that area. So really important. And also, I will talk about this later in more depth, but that high blood pressure is associated with a complication called autonomic dysreflexia. All right, so DVTs at risk, cardiac. We're going to talk about cardiac. So DVTs are a risk, so you're going to want to give them anticoagulergics if they don't have a hemorrhage, of course. CDCs, dangling and walking, sitting in the chair, which is very different because dangling their feet is like contraindicated in the amputation, which is interesting because of the edema swelling, but in this it's not. So that's interesting. Also, to prevent DVTs, range of motion. This is really important to remember. 5 reps each extremity for 3 times a day. 5 reps each extremity, 3 times a day. At what degree? 45-degree angle, if you want to get them sitting. And this prevents contractures from happening. So before range of motion, you want to give them protonics. Just remember this, because C4 above injuries, they're at risk for not controlling the breathing, so they're at risk for aspiration. They have no control of their respirations, at risk for aspiration death. Why? Just think of like a roller coaster ride, and you're getting moved, but you're not really in control, and so that can get the patient to throw up, but they can't actually control their breathing, so then they aspirate on it, and so it's really dangerous. So just before that, just make sure they have protonics. Other things to monitor for is above T6 causes hypotension, bradycardia, vasopressors. So you want to use dopamines, anticholinergics like atropine, and fluid and electrolyte replacements, as we talked about. So anticholinergic is a parasympathetic blocker. Acetylcholine block, it increases the sympathetic system. Fight or flight is going up, rest and digest is going down, so slow down of HCl production. Side effects would include your classic anticholinergics would be dry mouth, constipation, and blurred vision. Just know it. Other things to watch for, especially if there's how would you know if there's a bleeding or oxygen problem? Hematocrit would be your counting of blood, hemoglobin, that kind of shows your oxygen levels, carrying capacity. All right, so the next thing I want to look for is respiration. C4 or above. C4 or above, your head, your neck area. C for your neck area. They're going to need mechanical ventilation because they can't breathe on their own. So monitor for that. The GI system is also really important because remember I explained before, I'm just repeating basically. GI, their stress ulcers, give them protonics. Yeah, that's just really important. The NG tube for paralytic ileus to monitor the fluid electrolytes because you're taking out that acid when you just help with that distension, but it could also cause being more alkaline because you're taking away the acid. Evaluate their swallowing because they may be able to swallow if they don't have a C4 problem. Proteins, you want to make sure that their albumin levels and their protein is going up in their nutrition to help facilitate as much healing as possible. The lack of movement causes demineralization of bone. So this predisposes this excessive calcium in the blood, makes them at risk for kidney stones. So be mindful of that. So extra calcium would not be helpful in reducing that risk. All right, so the next thing is the complication that I wanted to mention about was autonomic dysreflexia. Super important. So this is a uncompensated cardiovascular reaction. Can you imagine if you had basically it's like a panic attack, if you think about it, because it's like as if you literally go up and up and up and up and you can't go down. Your body literally doesn't have the parasympathetic system, which usually it has. So you can usually go up and down and like even out and be like normal, but that doesn't happen in this case. So uncompensated cardiovascular reaction is mediated by the sympathetic nervous system. So your nervous system's going up and it can't go down because there's no parasympathetic system. You want to elevate the head of the bed. The signs and symptoms you're going to see is a headache, high blood pressure, flushing of the skin. What are you going to want to do? You're going to want to check for making sure they have an immediate catheterization because you're supposed to do that every 3 to 4 hours. If there's a stool impaction, you see that, relieve it right away. If it's not relieved, provide nifedipine, which is a calcium channel blocker to reduce that blood pressure, and teach the signs and symptoms to the patient. like the nurse has to know, but also teach it to the patient because they're coming home with that spinal cord injury. High blood pressure, flushing of the skin, and the headache. That's the main things to know for autonomic dysreflexia. The other complications I wanted to focus on is monitoring, again, for those DVTs, check the leg girth. Is it warm or deep red and swelling? These could be signs of a DVT. Is leg girth getting bigger? Check temperature, color, and a duplex Doppler will help you assess for that because the patient may not feel pain or anything like that. So also hypovolemic shock, which is could be secondary to a hemorrhage, or hypovolemic shock associated with the T6 above sympathetic nervous system not working. Okay, the two main things I want to focus on, the last complications would be spinal shock and neurogenic shock. So I'm just going to explain the differences real quick, and then we could be through. So spinal shock is going to be focusing on just, think of your motor. Decreased reflexes, loss of sensation, flaccid paralysis, below the level injury. The syndrome may last several months, and they may mask the post-injury neurologic function. So you may think this is the neurologic function, and they get their a little bit of function back. You don't know. So just think of everything decreased. Decreased reflexes, loss in sensation, flaccid paralysis below the level of injury. Neurogenic shock is a bit different. It's more focused on the peripheral vascular system. So it says, due to the loss of vasomotor tone caused by the injury and characterized by bradycardia and hypertension. Remember, so it's more peripheral vascular you're looking at. The loss of sympathetic nervous system. The innervation caused peripheral vasodilation. That's going to lower blood pressure. You're going to see venous pooling because there's less, that dilation means it's not going up. Decreased cardiac output, and usually associated with cervical and high thoracic injuries, especially T6 or higher. Why T6 or higher? Because you're thinking of your sympathetic nervous system. So that's everything you need to know for spinal cord injuries, and good luck studying and happy studying. So good luck, everybody.